Okay, it looks like it's time for us to get started. I want to welcome everybody. Thanks so much for joining us today. This is our Behavioral Health webinar series with the Native Center for Behavioral Health. This is part of our project titled the National American Indian and Alaska Native Addiction Technology Transfer Center. And today we have Dr. Edwin Salzitz presenting from ASAM for us on pain management and opioids, balancing risks and benefits. This training series is brought to you by the National American Indian and Alaska Native Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which will include a link to the recording, handouts of the slides, and a CEU request form. I also wanted to note here that Dr. Salzitz and those at ASAM also have this course available for CME credits, and there's another piece that would need to be done if people are interested in CME credits, and we will explain more about that later. Our center is a NADAC certified educational provider, and we'd be happy to provide you with NADAC CEUs for a $15 fee. And the form to request that is in the files pod, but we'll also be sending this out in our follow-up email. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so please use the chat pod to share your questions and comments, and we will have time at a couple of points during today's presentation to address those questions and comments. I'll just let everyone know now, we will be taking a break since this is a longer webinar than our regular series. So we will, Dr. Salzitz will be presenting for about an hour, and then we'll take about a 15-minute break at that point, so people can get anything they need at that point, and we'll come back after about the 15-minute mark. So we will take some time for questions before that break as well. Our speaker today is Dr. Edwin Salzitz. Dr. Salzitz has been an attending physician at the Mount Sinai Beth Israel Division of Chemical Dependency in New York City since 1983 and is an assistant professor of psychiatry at the Mount Sinai School of Medicine. He is the principal investigator of the Methadone Medical Maintenance and Office-Based Methadone Maintenance Research Project. So excited that we have Dr. Salzitz here to teach on this topic. I do just want to make sure that people know normally or quite often we really try to have our content in these be culturally informed for our Native audience, and I just wanted to make people aware that this content today is not a Native American focused content, but we wanted to offer it because we thought this would be very valuable to our audience. So I just wanted to preface it with that so the expectation isn't there that this would be a focus for the Native population. So with that, I would love to pass things over to Dr. Salzitz, and thank you so much again for joining us.
Okay, thank you very much, Kate, for that introduction, and thank you everybody who is on the on the webinar at this time. I hope wherever you are the weather is good. It happens to be good where I am in New York City. And our topic today is pain management and opioids, balancing risks and benefits. So this is kind of a big, broad overview of the topic, and I'll try to make this informative and try to kind of get through the material as quickly and as best as I can. I'd like to hold the questions that you're going to ask until the very end. We'll leave time because there's so much content in the course that very often the questions that you might be thinking about wind up getting answered as we go along. So you heard about me. I've got to just say that I'm an internist by training, and then I did pulmonary medicine for a while, and about 30 years ago I segued into addiction medicine, and addiction medicine has become a lot about opioids, and that brought in pain, and so that's how I got into this area of pain, opioids, addiction, and it's been a very interesting 20 years or so now in terms of this whole prescription opioid epidemic. So I am representing the American Society of Addiction Medicine, and we are one of the groups involved in this collaborative for risk evaluation mitigation strategy called CORE REMS course, and there are other groups involved as well. I think you'll see a slide very shortly. One thing that you need to know is that some of the funding for this course is provided by a company called Indivior, and Indivior is one of the manufacturers of some of the buprenorphine products. However, none of the pharma companies that may contribute to the course have any impact or any say on content, speakers, anything at all. Well, these are some of the other organizations involved in the core group, and again, this is ASAM. I don't know if you can see my mouse on ASAM. There was a way to make that happen, but I don't have it on my screen right now. This is the faculty group. I'm a member of this faculty group, and this is the group that makes up the content that you're going to see today. And the content is made according to directions from the FDA. They have an FDA blueprint, and they decide what should be covered. The only thing you need to know about all the faculty members is that none of us have any disclosures or any conflicts related to the content of the course. So some of the objectives are to talk about the pathophysiology of pain, how do you assess patients, how do you put a treatment plan together, what about non-opioid or non-pharmacologic treatments for pain, and then we'll talk about opioids, but the course used to be primarily about opioids, and now it's still about opioids, but we've narrowed it down and have other topics involved in the treatment and evaluation of pain. But in terms of opioids, how do you start people, how do you manage it, and what about opioid use disorder? We'll talk about that in the last chapter. So why are we here? Well, we're here because the prescription opioid epidemic, and just the opioid epidemic now, has really been a unique event in the history of the United States in terms of the number of deaths and overdose deaths related to opioids, starting with the prescription opioids. And you can see in that first box that misuse, diversion, addiction has created a public health epidemic. Now, the next box says that when prescribed well and used as prescribed, opioids can be valuable tools for effective pain management. And we'll dig into that a little bit more because there is a debate about how good the evidence is to support this statement. And we'll talk about that as we go along. There are always unintended consequences of any policies, and one of the unintended consequences, it has been misinterpretation of the CDC guidelines, and when we come to that, I'll elaborate on what I mean by that. As I said before, the content of the course is determined by the FDA, and then we, the faculty, work on putting the content that they request into the course. And the last box is an important statement as well. This course does not advocate for or against the use of opioids, and that would be chronic opioids for chronic non-cancer pain. We intend to help healthcare providers manage pain without putting vulnerable patients at risk for misuse or opioid use disorder. The goal is to keep our patients safe, our communities, and ourselves safe. So that seems like an obvious statement, but it's a good thing to reiterate. So this is basically a look at the last 17, 18 years of what has happened in the United States. And it really is a remarkable set of circumstances. The green in the graph represents the amount of morphine milligram equivalents sold in the United States over this time period. And I know that from 1999 to 2010, only 10 years, the amount of opioids prescribed quadrupled, opioid overdose deaths quadrupled, and admission to treatment for opioid use disorder quadrupled. And that was really the height of the prescription opioid epidemic, the decade of the 2000s. It began in the late 1980s and 1990s. It really got going, but the 2000s were the height of it. So the black line are opioid overdose deaths, and here are the deaths on the left side of the screen. And they have continued to go up. There's been a slight tapering down in 2018, which is not shown on this particular graph, a slight decrease. But you may remember that this is about 50,000 deaths now in 2017. Those are the opioid ones. The total deaths was 70,000 something. And the prescription opioid these are the prescription opioids in the blue line. And they went up, and then they leveled off, and they've gone down dramatically with all the education, the PDMPs, etc. But one of the unintended consequences in 2010 was the rise of heroin. And this happened, one of the reasons it happened is that people were being much more judicious about their prescribing, and meanwhile, people who were physically dependent on opioids could no longer get their prescription opioids, and heroin was available, it was cheaper, and so people switched to heroin. And if that was not bad enough, starting in 2013, we started to see fentanyl coming in and contaminating heroin. And these days, the most common overdose death is due to fentanyl. And fentanyl not only contaminates heroin, but it contaminates all illicitly sold and used drugs like cocaine, alprazolam tablets, hydrocodone tablets. So fentanyl is the big problem. We'll talk a little bit more about that. But this really does encompass the entire opioid epidemic over the last 20 years. So opioid analgesics. You know about the scheduling by the DEA. Schedule 1 includes things like heroin and controversially cannabis. Schedule 2 is where most of the opioids that we prescribe and that led to the prescription opioid epidemic reside. High potential for misuse and opioid use disorder. Schedule 3, potential for abuse, which may be less than Schedule 2. And here we have buprenorphine. And because buprenorphine is in Schedule 3, it comes under very different regulations than the medications in Schedule 2. And this is unusual here now. In Schedule 4, we have the benzos, and it says low potential for abuse. That should certainly be in quotes, because the benzos are a very significant part of the whole prescription problem. In at least 30 to 50% of opioid overdose deaths, benzos are found on postmortem toxicology, and most deaths that are listed as benzo-related have opioids. So they kind of go together, and nobody knows exactly what to do about all of this benzo prescribing, but it certainly is a problem. And then they have low potential for abuse, and interestingly, they list gabapentin and pregabalin, the gabapentinoids, which are an emerging group of medications which are causing a lot of problems, misuse, adverse effects, people with addictions taking super therapeutic doses. Pregabalin is definitely a Schedule 4, but gabapentin is only scheduled in about 3 states right now. People are talking about getting it scheduled across the country, but it is not yet scheduled by the federal rules. Fentanyl, back to fentanyl for a moment. So up here, you can see this is supposed to be the lethal dose of heroin for an adult male, lethal dose of fentanyl, couple of grains of carfentanil, which is an analog of fentanyl. If heroin is 1, or if morphine is 1, then heroin is twice as potent as morphine, fentanyl is 100 times more potent, and carfentanil is 10,000 times more potent than morphine, sometimes called the elephant tranquilizer, and it has been found in overdose deaths. I know there was one report with many deaths ascribed to carfentanil, which occurred in the Dayton, Ohio area. So fentanyl is really what's going on right now in terms of overdose deaths, contaminating or replacing heroin, cocaine, other illicit drugs. The fentanyl that we're talking about does not come from pharmaceutical products. This is fentanyl and its analogs, which are being synthesized in laboratories in China and imported in somehow from China, either through the mail, through shipping, through the Mexican border. Interestingly enough, there are two ways that people die of a fentanyl overdose. One way is the traditional respiratory depression, opioid respiratory depression, where over a limited amount of time, but certainly some time, respiratory rate goes down, tidal volume goes down, PCO2 up, PO2 down, and then if it's not reversed, you die, and you get in there with naloxone, there's time to reverse an opioid-induced respiratory depression death. But if there are any anesthesiologists on the webinar, they will know for the last 30 years that rapid IV infusion of any of the fentanyl drugs will cause what's called can cause what's called chest wall syndrome or wooden chest, where the muscles of respiration are paralyzed, the muscles in the larynx are paralyzed, and the person cannot ventilate. These deaths occur within minutes, and there's generally no time to get to the victim with naloxone. And I mentioned this before. This is becoming a huge problem. People are coming into the EDs, known cocaine-addicted people, and they're presenting with opioid overdoses, and sometimes they're dying because, as opposed to people on heroin, the people on cocaine and methamphetamine do not have any opioid tolerance. And when they take a potent opioid like fentanyl, they're much more likely to overdose. So here is some specific data about Iowa. They're talking about prescription opioid prescribing per 100 people, and you can see that through all the efforts, we'll talk about some of them as we go along, prescribing has gone down. And there has been a dramatic decrease across the United States in prescribing of prescription opioids. Some of that has been good, and some of that has not been good. Some providers have cut people off who were doing well, functioning well, and have caused those people to have tremendous problems up to and including overdosing on heroin and fentanyl. So with opioids with addiction, there are always unintended consequences. 2017, you had 206 overdose deaths related to opioids. The United States had 47,000. I'm not remembering the exact map of all 50 states, but I know that Iowa is relatively low. I think you're below the 50% rate of the highest states. The highest states throughout this whole epidemic have always been West Virginia, Ohio, and other parts of Appalachia, and for some reason New Hampshire has also been a state with very high rates of opioid overdose. It varies state to state, sometimes in a way that can be understood, other times not able to understand. So risk versus benefits. This is talking about opioids now. So all of us know the risks, particularly of overdose deaths, other people in the household getting hold of the opioids. They interact with other medicines, particularly the other CNS depressants like alcohol and benzos. We'll talk about pregnancy in a couple of slides coming up. And we don't want people getting exposed who shouldn't be. So, for example, there are a number of reports about children rolling over on a fentanyl patch that was taken off but lying around someplace. There's still a lot of fentanyl in those patches, and there have been reports of children overdosing and dying. Same thing for pets like dogs rolling over on a fentanyl patch. Respiratory depression we've talked about. We're not going to talk much about immediate release versus extended release, except to say that it's always more dangerous with extended release long-acting opioids because they generally contain more milligrams of whatever the opioid molecule is. So those are the risks of opioid prescribing or opioid use, but of course there are benefits, and the main thing we're looking for is analgesia. We want to treat pain, particularly acute pain. We want to treat chronic pain, that's more complicated. We do want to use long-acting opioids in a rational way. If somebody's going to be on long-term opioids, there are benefits to the extended release long-actings, which we'll talk about. But this is the bullet that I think is now the most important bullet, this one and this one. Improve function, improve quality of life. What happened during the prescription opioid epidemic is we would only use the pain score. And people would say, oh, my pain went from a 7 to a 5, and everybody thought, wow, that's a great achievement. But most people with chronic pain are never going to go to a 0. And what we really want is we want people to function better and have a better quality of life if they're going to be on chronic long-term opioids, because many people think the pain scales are really not too valuable or valid because they're so subjective. So a little bit about pain. And this slide, in our format here, we don't have animation, but this would have been an animated slide where we start with a peripheral injury. So this is an example of nociceptive pain. Somebody steps on a nail, and pain fibers transmit that sensation peripherally into the spinal cord, where it crosses over onto the contralateral side. And there are different fibers. There are delta fibers, delta A fibers and C fibers. Some transmit more quickly, some transmit slower. When the pain signal comes into the spinal cord and crosses over, it goes up the spinal cord, and at each area there is room for modulation. So the pain stimulation may be stronger in some people here, may be dampened in other people. In any case, it travels up into the thalamus, and then from the thalamus goes to different parts of the brain. The different parts of the brain are actually important. One part of the brain that the pain signal goes to is the somatosensory cortex, and that tells you where the pain is. So in this case, you'd be able to say, the pain is in my right foot, in between my big toe and the second toe. It will tell you the nature of the pain, that I think it was a little pinprick that happened. It will tell you in some way how serious it is, how painful it was. However, the pain signal also goes to a part of the brain called the limbic system, which deals with feelings, emotions, and reactions to the pain, the afferent response to pain. And that will be kind of like, what does this pain mean to me? Oh, it looks like a minor little problem. I don't have to worry too much. I had a tetanus shot last week. The thumbtack is clean. Or, wow, I'm so worried. Maybe it's a serious injury. Maybe I need to go to the ED. So that kind of modulation occurs in the limbic system. The other pain pathway that gets stimulated when the pain signal comes up into the brain is the descending pathway. And we'll talk a little bit about that as we go along. But the descending pathway can block the signals coming up from the periphery. And I'm sure that you all know that norepinephrine and serotonin are important neurotransmitters involved in the descending pathway. So now the content also wanted to say that there are peripheral pain modulators and more central pain modulators. So there are a whole list of modulators peripherally, like histamines, prostaglandins, bradykinin, substance P, which modulate the pain, and in different people it's going to feel differently. And in terms of the descending pathway, I mentioned serotonin, norepinephrine, the endogenous opioids, substance P, which is pro-nociceptive, so that should be blocked by the descending neurotransmitters. Anyway, that's a rough outline about how pain gets transmitted. And now we have a little digging down a little bit deeper. Here's the injury again over here. And again, it's looking at all the different peripheral mediators of pain. And some of them we think about when we think about how we're going to treat a person. Because the point of going through this is to say, well, prostaglandin may help decrease the intensity of the peripheral signal into the central nervous system. So that might be a good medication to choose. Or it could be that there are calcium channels involved in the pain transmission, and the gabapentinoids can decrease those calcium afferents that bring the pain signal in. Feeling physical pain, yeah, this is important. So acute pain is very, very important, because acute pain is telling you that something has happened and you need to pay attention to it, and you need to decide what you need to do. So acute pain is vital for animals to survive. Chronic pain has really no evolutionary advantage, no function. And so chronic pain is often considered a kind of a disease in itself, since it doesn't really help in any way. But acute pain is vital for survival. Back to opioids for a moment. So as you probably know, there are different types of opioid receptors. There's the mu receptor, delta, and kappa receptor. For our purposes today, we'll speak mostly about the mu opioid receptor. That's the receptor primarily involved in analgesia from the opioids we give people, and also involved in opioid use disorder in the limbic system. So what's interesting about Mother Nature is that mu receptors are widely scattered in the brain. In this slide, 3 regions are circled. One is the periaqueductal gray area, which is a main analgesic center in the brain. And when somebody takes, let's say, oxycodone and they have acute pain, we hope that the oxycodone will hook up to the receptors here, attach to the receptor, and thereby mediate analgesia. However, the oxycodone is also going to go into the areas of the limbic system, the nucleus accumbens. And so some people, not all people, might feel a euphoria when they take that oxycodone if this area is stimulated and that person's vulnerable. Back here in the brainstem, there's a part of the brain called the locus ceruleus. This is where opioid physical dependence and then withdrawal are occurring. This is a norepinephrine center of the brain, and we'll talk a little bit more about that later. And of course, all of this is in context and connection with the prefrontal cortex, which is where we decide if something is a good idea or not a good idea to do. So that's in the brain. There are opioid receptors peripherally. There are opioid receptors in the spinal cord, and they're also involved in opioid-induced analgesia. As you know, there are opioid receptors in the GI tract. Same opioid receptors as in the brain, but these receptors subserve constipation. So the idea is that Mother Nature uses the same opioid receptor throughout our bodies, but depending on where they're located, they subserve a specific function. So for example, one of the problems with opioids is urinary retention because there are opioid receptors in the bladder. Types of pain. Okay. So I think the most common pain we think about is nociceptive pain, where there's some sort of injury. You can either see the injury, you can visualize it, and some imaging study, and typically this pain is acute. And here are some examples that you would know: postoperative pain, sports injuries, people with sickle cell disease who have crises are constantly in acute pain, and a very, very common acute pain is back pain. So that's nociceptive inflammatory pain. I want to skip over to neuropathic pain, another category that you're all going to be familiar with. And this does not have to do with tissue injury. This is some sort of abnormality or injury to the nerve itself. And then the impulse, the pain impulse, continues to be transmitted along that neuron. And good examples that you would know, common examples are post-herpetic neuralgia, diabetic neuropathy, trigeminal neuralgia, and others. A new type of pain designation, this only came around in 2018, is called nociplastic pain. And this you might recognize as the term sensitization, central sensitization, where the person is in pain, there's no obvious injury, there's no obvious neuropathic pain signal, but they just feel pain, usually diffusely, chronically. And some examples of that are fibromyalgia, irritable bowel syndrome, and people that have ongoing musculoskeletal low back pain. And the new designation here is nociplastic. And you'll see why this might be actually therapeutically important in a slide or two. And of course, there's always the mixed type of pain. And the idea here is that if you were going to be really thorough in your pain evaluation, you would say, what type of pain does the person have? Is it peripheral? Is it central? And acute or chronic? And that might lead you into the right treatment of the pain. Okay. Yeah, this was definitely an animated slide where these things would come in a few at a time, not all at once. But this is getting to the concept that pain is a biopsychosocial spiritual phenomenon. That pain is not just my finger hurts, is what does that mean? How does it affect me? How does it affect my work, my relationships? And so the idea here is to present the concept that pain is complicated. that one person's pain is going to be not a big deal. They're going to continue to work. They're going to continue to do everything they have to do at home, with family. And with other people, it's going to be a catastrophe, even though it appears that it would be the same level of pain. So that's what the slide is trying to get to. All the different factors that contribute to the big four parameters of pain. And putting that all together leads to the experience of pain in each individual. There have been a number of publications, and a few people on the faculty were very familiar with these publications, that the more empathetic the provider is to the patient, the better the patient does in terms of their pain, no matter what the source of the pain is. And I don't have the quote in the slide set, but there was a wonderful article a number of months ago in the New Yorker, and I'm going to paraphrase the quote, and that is that somebody wrote a book about pain, and they said, to have pain is to be sure of its impact or its suffering. If you have pain, you know you have pain. And then it said, to listen to somebody else's pain complaint is to have doubt. And I thought that was a really good quote, that when we have pain, we don't doubt that we have it. But when other people have pain, we sometimes are not sure how valid their complaint is. So on this slide, we have this issue of pain catastrophizing. We have a validated screening tool for that. And basically, these are patients who have pain, and pain kind of dominates their lives. It impairs their function, their quality of life, their relationships with people. They tend to see a lot of healthcare providers, get a lot of testing and imaging, and these people probably would do well with more of a psychological approach to the pain, and the psychologist might be the best person to help with their pain as opposed to a pain specialist. These are going to be more difficult patients to take care of, and so the slide set wanted you to know there is such a thing and there's a way to evaluate it. It doesn't give me the exact numbers and what they would mean, but I think you understand the concept behind pain catastrophizing. So how do you resolve pain, or how is pain treated? And on this slide, they're showing you different non-pharmacologic modalities to treat pain: physical therapy, yoga, hot and cold compresses, and CBT, psychological methods of treating pain. And this is kind of where the field is going. Here's acupuncture, which has evidence as well. So that was chapter 1, very brief chapter on terminology. So words matter, and we have a little terminology here because one of the problems, certainly in addiction, but also with chronic pain, is stigma. That people don't believe they have pain, or think they're faking it, or trying to get secondary gain. So the word addiction is no longer used in the DSM-5. The term that's used for everything is substance use disorder, whether it's opioids, cocaine, or alcohol. I don't find addiction to be a pejorative term. The term I don't use is addict. I usually say person with the disease of addiction or substance use disorder, but I don't usually say addict. I find it to be kind of harsh and negative. So here they're saying that maybe there's a problem with the term aberrant or problematic behavior, using medication not as prescribed. But this is a definite. I was one of the first people 30 years ago to say, why are we saying clean and dirty urine? This is street terminology, slang terminology. Urines are either positive or negative for whatever they're positive or negative for. Can you imagine going to any other healthcare provider and giving a urinalysis because you have a UTI and somebody came back and said you had a dirty urine? And I'll let you look at this at your leisure because you're going to have the slides. Just point out a couple of things. All these different words have come about. The word misuse is no longer considered a useful term. It's been supplanted by misuse or substance use disorder or addiction. Tolerance, I think you all understand. Physical dependence means that when you stop using what you're physically dependent to, you develop a withdrawal syndrome. So withdrawal syndromes are evidence of physical dependence. Withdrawal syndromes can be catastrophic, like alcohol sedative withdrawal. Opioid withdrawal is also a difficult withdrawal, but it doesn't come with morbidity. It doesn't come with mortality the way alcohol and sedative hypnotic withdrawal does. And sometimes the withdrawal can be relatively subtle and minor. I'm thinking of nicotine or cocaine or food, but yet there is going to be withdrawal. We'll be talking about morphine milligram equivalents a little bit later on. Chronic pain is defined as anything lasting for longer than 3 to 6 months. Okay, so how do we assess patients? Well, so these are patients coming in with a pain complaint. We want to know, where is the pain located? That might help us understand what it is. What is the intensity of the pain, the quality? Is it burning? Is it shooting? Is it sharp? Onset, duration. So the problem here is that the more you know about pain syndromes, the more you can zero in on what might be the diagnosis. So for example, carpal tunnel pain is worse at night. Diabetic neuropathy pain is worse at night as well. So that might, lead you into thinking that that would be the right diagnosis. I guess that goes over here, the variations in terms of the diurnal variation of the pain. What relieves the pain? What medications or what maneuvers or exercise? What increases the pain? And again, this might help, it might not, but this is the most important part here. What impact does the pain have on your function, on your quality of life? And this gets back to that catastrophizing slide. Has the pain taken over the person's life, or are they functioning? I know myself, if I can interject about myself, I had a left hip replacement 3.5 years ago. Never during that whole period of time was there any effect on my ability to function, take care of what I had to do. It didn't have that impact on me, yet in some people it has a major impact. And what is happening right now with pain and function? I don't know if anyone's a physiatrist on the webinar, but I once heard a physiatrist say, I guess in a suburban office, that he stands by the window, he looks at new patients coming in, parking their car, getting out of the car, and as they walk through the parking lot, depending on their posture, their limp, how they're holding their bodies, he says he's often able to tell exactly what the diagnosis is going to be. So I think that that's fabulous. I'm not that good. We want to know about what non-pharmacologic strategies have you used. Did you go to PT? Was it effective? Very often people will say PT wasn't effective and they maybe went once or twice or couldn't access it. What have you used pharmacologically? Non-opioids, opioids. Are there any comorbidities that are important? For example, if you were thinking about opioids, do they have severe COPD? Might not be a good idea. Or do they have underlying constipation, GI problems? And of course, we're going to look at the PDMPs. All states have them now. They vary in terms of how often you have to check, etc., but it's really a good idea to check the PDMP. This is easy to talk about in a webinar, but not that easy to do in real life. But if you can get old records and old providers give you some information, that would be great. Opioids, you want to know what they're taking. Determine whether the patient is opioid tolerant. That's going to come up in a slide or two now, and you'll see why that the FDA thinks that that's important. Prescription drug monitoring programs, I'm thinking that I don't have to spend much time on this. I think everybody uses them now. In New York State, anytime you prescribe a controlled medication, it is mandatory to look the patient up in real time. I know in some states that's not the case, and I kind of scratch my head as to why have a PDMP then. And the PDMPs have been shown to reduce doctor shopping. There are 1 or 2 articles showing that they've reduced prescription opioid overdose deaths. However, the other thing that they've done in an unintended consequence is they've made some providers squeamish about prescribing and cutting off people abruptly, which has led to very significant negative outcomes. But you want to know if you're thinking about prescribing an opioid, whether somebody's getting a benzodiazepine or any other sedating medications. So can never go wrong with getting a complete history and physical. In my humble opinion, in terms of chronic non-cancer pain, this is where most of the important factors are in the effect of the pain on their life, their family, their work, if they intend to go back to work. This is where a lot of the issues are, and you need to understand this very, very well. And continuing along with that, this is really psychological history. What mental health diagnoses do they have? What have they been treated for in the past? Make sure you ask about alcohol and tobacco. Both of these are risk factors for opioid use disorder in patients on opioids. This has become a big topic now, adverse childhood experiences. These folks, unfortunately, are at risk for a lot of negative outcomes, certainly at risk for opioid use disorder if exposed to opioids. The risk of addiction is about 50% genetic or familial, so you want to know about family members. And depression and pain go together very commonly. 50% of people with depression have chronic pain. 50% of people with chronic pain have depression. So we want to know if that's in the picture. Physical exam, we're looking for, this is the idea that, okay, the person has chronic pain, because in acute pain, it's going to generally be obvious where the pain is coming from. So this is more chronic pain. And we want to try to make a diagnosis, which is nice if you can do it, but not always possible. So seek objective data, conduct a physical exam, and again, a general exam, a good neurological exam. Those certain maneuvers like straight leg raising and other maneuvers, if you're familiar with them, can pinpoint what the pain might be due to. Depending on how they walk, you might think they have spinal stenosis, or if they're walking kind of crooked sideways, maybe they have a disc problem. So that's all in the musculoskeletal exam. And again, you know, some people are much better at doing these than other people. Here we have a caution that we as providers order too much imaging too early in the course of seeing the patient. And the classic study was done in the New England Journal of Medicine a number of years ago. And I don't remember the exact details of the study, but let's say it was something like 100 asymptomatic people, I think it was over the age of 50, got MRIs of their spine. And I think it was something like 60% of the people, asymptomatic, had evidence of abnormalities like bulging discs, where had they had pain, that abnormality would have been ascribed to the MRI finding, even though they were asymptomatic. So that's the problem in doing too much imaging too early, is you're going to find abnormalities which are not going to be necessarily related to the pain complaint. And if people have atrophy of muscles or limbs, that might give you some clue as to how long things are going on or what the problem is. So as you know, there are many assessment tools and screening tools that you can use in all these different categories. Some of these tools are embedded in EMRs. Some people find using these type of tools to be useful. Others don't find them to be that useful. So here they are. Look at them when you have time. Pain assessment tools, quality of life, do you enjoy your life, general activity, childhood trauma. So these things can all be effective and help you sort of zero in on what the main problem is. Okay, so we talked generally about pain, a little bit about opioids so far. We just did an assessment of the patient, and now we're going to try to put together a treatment plan based on the information that we have accumulated up to this time. So, again, easy to talk about it in a lecture or a webinar, having a multidisciplinary pain treatment group. So you want to have your staff empathetic, understand everything about what's going on in the clinic or in the program. You want to hopefully have someone who can do good cognitive behavioral therapy and other forms of psychosocial treatment like motivational interviewing or dialectical behavioral therapy. You want to have a pharmacotherapy kind of person around, a pharmacist who might help which drug would be best, what are drug-drug interactions, and again, the physical therapy, the occupational therapy, and here you are, the provider, working with all these different people. In other slide sets, they'll have an addiction medicine specialist up here. they'll have a pain specialist, and in these types of multidisciplinary clinics, they have one at the Cleveland Clinic, for example, they have very good outcomes. And I don't think that's surprising when you think about this whole big team. Most of us don't have access to this kind of teamwork, but you may have access to one or two parts of it. Another slide that should have been animated. So how are we going to think about treatment? Well, we want to have a multimodal approach. We don't want it to just be one thing. So we want to first think about cognitive behavioral therapy or psychosocial treatment. And this could be cognitive behavioral, motivational interviewing. We want to change how people think and feel and react to their pain, since most people in chronic pain will have chronic pain for the rest of their lives and will have to learn to adapt to it and live with it. Then we have the physical treatments, so the physical therapy, acupuncture, movement therapies, manual treatments. I'm thinking some of you have engaged in these treatments and they really do work well. They really work well, but the problem is they're hard to access. Sometimes insurance doesn't cover, and that's a difficult issue. Then we have pharmacotherapy, and the medications here are listed in no particular order. We have the NSAIDs, which come with their own set of side effects, though. Some of them pretty severe. We have the antidepressants. We have the anticonvulsants. They're commonly called adjuvant treatments. We have the opioids, which we'll dig into. We have the emerging field of what about the cannabinoids? What about cannabis? A very hot, confusing topic right now. And we have topicals, which we often don't remember. We have lidocaine. We have capsaicin. We have a topical gel NSAID medication. And then we also have the whole interventional category. And at least where I'm working here in New York City, it seems to me that most of the pain specialists are now doing primarily interventional, not so much pharmacotherapy. And there are different forms of interventional treatment. Some of these come with their own controversies, epidural injections, how often, how durable are they. The one that I've seen the most emerging evidence for are spinal cord stimulators. They seem to be coming on more and more with good evidence of effectiveness and relative safety. So again, we're talking about a bunch of different providers all working together, trying to get the patient to be more of a self-care person, don't catastrophize, empower them to not be victims, and etc., improve the quality of life. Okay. Evidence-based non-pharmacologic treatments. And you remember that the CDC guidelines, which were published in March of 2016, the first recommendation in terms of treatment is non-pharmacologic treatments. Here's a list of all the non-pharmacologic treatments which have evidence of effectiveness for chronic pain. Again, not easy to access sometimes, not easy to convince people to do, but certainly something that should be thought about, particularly maybe in elderly people where there might be more polypharmacy, more interactions, more negative effects from opioids in older people. So there's a comprehensive list of all the modalities. Now, if we get past the non-pharmacologic, we have to get the pharmacologic. And how do we determine that? Well, we're going to do it by pain category. So that first category, nociceptive, could be acute pain. Certainly for acute pain, we're going to be thinking about using immediate release opioids, maybe nerve block, NSAIDs, topical, transdermal, for chronic pain, not for acute pain. For nociplastic pain, that's that pain that you can't really pinpoint, that might be a central or peripheral nerve sensitization where you're just getting a pain signal and there's no good reason for it to occur. Some of the medications that have shown some evidence of effectiveness, the anticonvulsants, these are drugs like duloxetine, gabapentin, venlafaxine, and other SNRIs and other anticonvulsants. Opioids are generally not indicated because they're not effective. Neuropathic pain, all those things I just mentioned, the anticonvulsants, the SNRIs, sometimes they say transdermal opioids. I'm not sure if it's here, there must be some evidence for it. And as you do pharmacological therapy, you should continue non-pharmacologic, like physical therapy, if that's accessible. Okay, so in this slide, there's an attempt to say that if the pain is peripherally mediated, let's say you stick yourself with a pin in your hand, you might want to try acetaminophen. Some people get some reasonable analgesia from acetaminophen. There have been a number of studies showing that it isn't any better than a placebo. NSAIDs block prostaglandin synthesis. As I said, they come with really serious adverse effects. It even says that after one dose, a person could have a myocardial infarction. We all know about renal, gastric problems with NSAIDs. And we have opioids for acute pain, and maybe topical medications could help too. And somehow, by using them, maybe we can decrease the intensity of the signal coming in, or maybe block it completely. And then in the centrally mediated pain, again, we're going through the anticonvulsants again. Here we have the alpha-2 agonists. So these are drugs like clonidine, tizanidine, which inhibit the locus coeruleus output of norepinephrine. And at least tizanidine has an indication as a muscle relaxant. Calcium channel antagonists, actually the gabapentinoids interfere with calcium channels and thereby have some pain efficacy. And NMDA receptor antagonists, the one that comes to mind now that's getting more attention is ketamine. People are using ketamine for acute pain to subside it, and people are using ketamine for depression. But ketamine acts as an NMDA receptor antagonist, the opioids, and the antidepressants again. So when you decide that you're going to use pharmacotherapy, again, everybody knows this because we do this with any pharmacotherapy for any disease that we treat. Decide on the route of administration, what formulation, the strengths that they come in, how often should it be dosed, what's the mechanism of action if it's known, what about drug interactions, which is so common through the cytochrome P450 system, and we'll talk about the opioid tolerance again in a minute or two. We want to know what the potency is relative to morphine. This is about using opioids now, and we'll dig in deeper on that. So this is just a general slide on any medication you're going to start. So we've done the assessment. We're trying to put a treatment plan together. We talked about non-pharmacologic, we talked about non-opioid, and now you're getting to, well, I think maybe an opioid might be indicated. Well, like anything in medicine, you want the benefits certainly to outweigh the risks, and the risks are a lot with opioids. Now, I'm talking about chronic non-cancer pain now, not acute pain. You'd like patients to fail on step 1 and step 2 before you consider an opioid, and you don't want them to have the nociplastic pain. You want them to have primarily nociceptive pain, not so much neuropathic. So one of the questions you're going to ask yourself when you're thinking about an opioid is, what about the risk to this patient of developing an opioid use disorder or just aberrant behavior or overdosing? And tools have been developed over the years to try to help you assess the risk. So these are some tools you would use before you started the patient. You're going to see the opioid risk tool on the next slide. This is a longer tool. And then once the patient is on the opioids, there are tools that will allow you to, oh no, I'm sorry. This is just tools, again, looking for risk of substance use disorder. So the DAS tool, there's something called audit for alcohol. Some of you are probably familiar with the CAGE tool, for originally developed for alcohol, but it can be used for any substance use disorder. Also, if you're going to prescribe opioids or any controlled substance, you should have the ability to do urine drug testing, and we certainly want to get a baseline, see where we start. We want to check the PDMP. So here is the opioid risk tool. It's recently been revised. It's looking for a family history of substance use, a personal history. Younger age. Younger people misuse opioids the most. Older people get the most prescriptions, but it's the younger folks who have the highest rates of misuse and also overdose deaths. So any psychological problem, any mental health problem in the patient is a risk. My problem with this scoring sheet here is that if you score less than 2, it's low risk, and then if you bump up one score, you're high risk. It seems like there's not much room here. And I want to tell you something else, that I'm not that good with high-level statistical analysis, but there have been multiple publications from very reputable people saying that there is no good evidence that these tools actually work, that the problem is that the opioids themselves are risky, and no tool can give you the confidence that the person's really not going to develop an opioid use disorder. So you have to keep that in mind as you go along. Side effects of opioids, there are a lot of them. The most serious one is respiratory depression, opioid-induced constipation. 50% of people on chronic opioids remain constipated. In other words, tolerance does not develop in 50% of people to constipation. Twitching, jerking can happen on opioids. It can happen getting off opioids. Sedation occurs, cognitive impairment. This is particularly an issue in elderly people. Some people have sweating. Everybody's got pinpoint pupils, urinary retention. Haven't heard about too many allergic reactions. Men, I don't know what percent, let's say 50%, are going to have decreased testosterone. Opioids inhibit the hypothalamus, and they're going to have physical dependence. It might be hard to get off the opioids. And something called opioid-induced hyperalgesia, which we'll have a slide on later. And these are adverse effects. Definitely falls in fractures, addiction, overdose, hospitalization. So these are serious adverse effects in terms of opioids. The most important adverse effect is respiratory depression. This is how people die. Probably more likely to occur in elderly, frail, cachectic people. They say the highest risk of opioid-induced respiratory depression is in those given concomitant benzos. The other high-risk situations are people starting on opioids or people having a dose increase. So all three situations are high risk, but the consensus is that the benzos and the opioids create the highest risk. Okay, so we want to go over the dosing carefully. Don't take more than we talked about. We'll talk about going from one opioid to another. Avoid co-prescribing benzos. And we don't want people in any way tampering with the extended release opioids. We don't want them opening the capsule. We don't want them cutting patches. We don't want them trying to break a tablet, because when you do that, you convert an extended release into a short-acting opioid. That was one of the big problems with Oxycontin, which was not tamper-resistant. 80 milligrams was the highest dose, so you had 80 milligrams of immediate-release oxycodone, and that was a big part of what fueled the prescription opioid epidemic and overdose epidemic. On the patches, which are basically fentanyl and buprenorphine, we don't want people to cut them. We also have to tell people to be careful if they want to sit in a hot tub or if they become febrile. That increased temperature, whether it's exogenous or endogenous, is going to increase the absorption of the medication through the skin, and particularly with something like fentanyl, it's going to potentially lead to an overdose. So that's a caution with that. Something about the MRIs, you can't go into an MRI, and that's the patches. So again, some of this we've already talked about, the respiratory depression. We don't want to use MAOIs. This was particularly true with meperidine, which is no longer used. Some opioids, methadone, can prolong the QT interval clinically significantly. Most of the other opioids don't. I talked about don't tamper with anything. Also, if you drink alcohol and you take a long-acting capsule, it may erode the capsule, and all of a sudden you got this dumping of the extended release and it becomes immediate release. Some people, when they start opioids, get peripheral edema. Opioids have an effect on ADH, and there are a lot of drug-drug interactions that you should know about. That's this slide here. Most of these opioids go through the 3A4 system, and these are the classic inhibitors of 3A4, and some of the inducers. Rifampin could be in here as well. Some people have different genotypes or phenotypes, these single nucleotide polymorphisms, which are not yet ready, I don't think, for clinical prime time. And most of the products come with very detailed, good product inserts. So we did this. I'm not going to do this again. We did the respiratory depression. Skeletal muscle relaxants basically are sedating drugs. We don't want to use partial agonists and antagonists while they're on a full agonist, because that will put them into withdrawal. The classic case here would be buprenorphine, putting people on buprenorphine who are on a full agonist. And anticholinergics, we want to be careful because of the urinary retention. Special populations. We're almost done. I'm going to go over a little bit past 2 o'clock Eastern time before the break. So older adults. Everything is more complicated than older people. They have different metabolisms maybe. They have renal hepatic impairment. So we want to be particularly careful about how we dose them and watch them carefully for respiratory depression. Start low, go slow. They do have increased falls, which can be catastrophic in an elderly person. So how do we do this? We reduce the dose, let's say, to half the usual dose, and even lower maybe. Start low, go slow. They tend to have more constipation, so maybe begin them on a bowel regimen like polyethylene glycol before you begin the opioids. And now we have the caregiver problem. We want to make sure that the caregiver understands everything, but we also want to make sure the caregiver is not the one stealing the patient's opioid medication, and there have been numerous cases of that happening. Women. So this slide is a little bit complicated because it's really directing its content at women who are pregnant, childbearing, who have pain but not opioid use disorder. And so it's saying, try not to prescribe opioids to them. If they're on long-term opioids, there will be neonatal abstinence syndrome. And generally speaking, young women who are pregnant, who don't have an opioid use disorder, you would think would not need to be on chronic opioids too often in terms of a chronic pain problem. Try to work with an OBGYN who is knowledgeable about this kind of thing. But let me just do a parenthetical guidance on women who have opioid use disorder. There is no controversy that women with an opioid use disorder should either be on methadone maintenance during the pregnancy or buprenorphine maintenance. That they should not try to detox off these medications. That 60 to 80% of the babies will have neonatal abstinence syndrome, will go into some form of withdrawal, which is relatively easily treated and managed as long as everyone on the team knows what they're doing. And every organization agrees with what I just said about methadone and buprenorphine during pregnancy. So if a woman had to be on pain medication, not with opioid use disorder, either methadone or buprenorphine would be the best, because there's the most evidence of safety with those two molecules as opposed to oxycodone or hydromorphone. Children, this is really simple. Any young person who's going to be on chronic opioids for chronic pain is probably going to have something catastrophic going on, and this would be handled by a pediatrician, a pediatric palliative care team. Interestingly enough, transdermal fentanyl is approved for children over 12, and oxycodone ER for children over 11. But this would be in conjunction with a pediatric team. People with sleep disorders like obstructive sleep apnea should be monitored carefully. Some people suggest getting a sleep study. Opioids increase obstructive sleep apnea. They don't make it happen, but they increase the apneic episodes. People with dementia, they're hard to get a history from. Obesity now is considered kind of an inflammatory problem, and people with obesity are going to have chronic pain that may be helped if they can lose weight. This has to do with dose adjustments. Psychiatric, we've talked about. End-of-life care is a separate category, and the CDC guidelines don't cover that. People with a substance use disorder, we'll talk about that in the last module. So when do you consider a trial of an opioid? Well, you got a 60-year-old man here. He's been on everything. He's got very bad osteoarthritis. Nothing has worked. He's got no psychiatric comorbidity, family history. So maybe you'd want to try an IR opioid, taking PRN to help him maybe play golf with his friends or meet his friends for coffee. Here's the opposite. You have a 30-year-old woman with fibromyalgia. Opioids are not indicated. She's got a substance use disorder. And the risk here would be very high to prescribe opioids for her. Could it be done? If that was what you came down to, it could, but she'd have to be monitored very carefully and probably should not be put on opioids. Okay, just a couple of more slides. We'll get to the break. I'm sorry. You want to get informed consent when you put people on chronic opioids. You want them to understand that they will develop physical dependence. It might be hard to taper off. These are the expectations I have of you, which comes up in the next slide, which is the patient-provider agreement, which is different than the informed consent. This is going to be how many visits we're going to have. This is going to be maybe one pharmacy. This is going to be, I'm going to be the only one to prescribe controlled medications for you. I don't want you to see anybody else. We'll be doing random urine drug tests, maybe pill counts once in a while, and we're going to do a trial. We may stop after a couple of weeks and I'll taper you off. And we both understand what my responsibilities are and what I expect of you. Again, some people use these, some people don't. They're in some EMRs. If patients don't adhere to the agreement, then the question is what to do. And what we say here is don't be too quick to fire people. Investigate. Some things seem beyond the pale, like forging prescriptions or violence. But other things might be understandable, reasonable, and the last resort is to say, I can't prescribe anymore. And if you do say that, you have to somehow refer the patient to some place where they can continue to get some form of treatment. Okay, sorry to go over a little bit, but it's about 2:05 or so Eastern Time right now. So why don't we reconvene at 2:20 Eastern Time? Okay? Okay. Anybody on the line now?
I'm here. Do you have a question?
Is this Kate?
Yeah, this is Kate.
No, my question is, you think things are going along okay?
Yeah, I think it's going great so far. I think, yeah, we've got a good number of people on, and yeah, it's been just super informative.
Is my volume okay?
Yeah, it sounds great, and you're great to understand. It's very clear, so.
All right, good. Because, you know, it's
Yeah.
funny to talk without seeing the audience.
Right. Yeah, it's hard when you're not getting any feedback, but
Right, I usually can
yeah,
look at an audience and I can tell how I'm doing and what's going on, you know?
yeah,
But okay,
yeah,
as long
for
as
sure.
it's coming across okay, I'm happy. That took a little bit
Yeah,
longer than the hour. I didn't realize that.
yeah, that's all right. Yeah, it's a content heavy piece, so
Yeah, a lot of
I can.
content, and I like to throw in some anecdotal material to clarify things.
That's so great. I think that's really helpful to understand some of that stuff. So I appreciate that a lot.
I see somebody here from Fairbanks, Alaska. Wow. Okay, you can do whatever you want now, Kate. I just wanted to make sure we were okay.
Great. Yeah, thank you.
Okay. 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 About that time, Kate, right?
Yep, maybe we said 120 or 220, so maybe just give it a couple more minutes.
What time is it where you are?
Oh, well, mine now shows 119, so
Okay.
maybe my watch is a little behind yours.
All right, Kate, I think I'm going to get ready to get back in.
That sounds good. I think we can get started. Thank you.
Okay, welcome back, everyone. I hope that was enough time to give you a little break. I'm really excited. I looked at some of the questions that people were asking, where they're from. Somebody from Fairbanks, Alaska, California, Kansas, Oklahoma. Wow, that seems very exciting to me. Somebody asked about what does the abbreviation OMT stand for. I know we have a lot of abbreviations and acronyms on the slides. I hope it stood for opioid maintenance therapy. I'm not sure where it was in the slide set, but often OMT is opioid maintenance therapy, meaning methadone or buprenorphine. And there were a couple of issues about the COWS, COWS, clinical opioid withdrawal scale. We usually use that before we induct people onto buprenorphine to have some objective way of determining how much withdrawal they're in before we start the buprenorphine. But we'll leave some time for general questions, hopefully at the end. Okay, so here we go, Chapter 5, Managing Patients on Opioid Analgesics. So, initiating opioids. Again, these recommendations are meant to be in line with the CDC recommendations, which really have become, I think, the standard of all the guidelines. Easily downloadable, March 2016, CDC guidelines for treating chronic pain. Always begin with an immediate release opioid, not a long-acting opioid. Lowest effective dose. The CDC guidelines said try not to go above 50 morphine milligram equivalents. That's not much. That's 2 or 3 tablets of oxycodone. So it's unlikely that people won't go over that morphine milligram equivalent. And then they're saying if you do go over, try not to go over 90 morphine milligram equivalents. And again, that'd be a more reasonable ceiling. They have pointed out in a number of publications that there was a misinterpretation. This wasn't supposed to mean that if you had a patient doing well on chronic opioid therapy on, let's say, 120 morphine milligram equivalents a day, that you were supposed to get them down to 50 or 90. This is supposed to be for new patients. Try to be judicious. Try not to go above this level. Give them good instructions. Response. Everyone should get naloxone. We have a slide on that coming up. Watch out for the chronic constipation, and keep reevaluating patients, because what happened during the prescription opioid epidemic is people would go on opioids, and then 10 years later their pain would be still the same as it was when they started, but they would just continue to take opioids and continue to sit on the couch. And we want constant reevaluation. Are we meeting our goals? And if not, let's do something about it, including tapering off opioids. Okay, yeah, so cancer pain, end-of-life care, the guidelines exclude those conditions from these opioid instructions. So they're on the opioid now. So now we're assuming that they have chronic non-cancer pain. You started them on the opioid because the other things didn't work. So are they making progress? We don't want the pain score to go from an 8 to a 6 and call that progress. We want function to improve. And if it's not improving, then we have to reset the goals again. Breakthrough pain, we'll have a slide on that. That's kind of a complicated, controversial issue in and of itself. And then what about the side effects? Make sure you're looking at them. There's a literature that says people are reluctant to talk about constipation, so you might have to open up the conversation and see if that's causing a problem. There's some really great medications now for opioid-induced constipation. There are medications that go into the bowel, stay in the bowel, and take the opioids off the receptors in the bowel and thereby relieve constipation, and they don't get into the central nervous system. You may know the name naloxegol or Movantik. That would be an example of one of these new medications specifically approved for opioid-induced constipation. For low testosterone levels, sometimes, depending on the case, that you might have to do testosterone replacement therapy. So now we're doing kind of monitoring. We're checking the PDMP. We're looking at urine drug testing. So again, if you are going to prescribe chronic opioids or chronic benzos, you need to have some way of doing urine drug testing. We'll talk about the specifics of that in a moment. Are they developing an opioid use disorder? Got to try to figure that out. And are they adhering to the plan? Are things going along well? And what about getting them off the opioids? When is opioid therapy no longer necessary? So if things are going along okay in terms of treating pain, we should be getting good reports about analgesia, good activity, function. We should have little to no aberrant behavior. We should have manageable adverse effects. And the patient should have a good affect. They should not be depressed. If things are veering over into addiction, one of the things we would have is loss of control. Person might be running out early every month of their medication, taking more than was prescribed, not being able to make it to the end of the month. Even though they're not doing well, they may want to continue and say they must have the opioids. They have a history of craving the opioids when they're not getting them or thinking about them. And even though it's causing harm, they want to continue to use them. And so substance use disorder is a chronic problem. And we'll talk a lot about this in the last module. So the person is on the IR opioid, let's just say oxycodone, 10 milligrams 3 times a day. What about moving them to an extended release opioid? Or maybe they were taking the IR opioid 4 times a day because it has a short half-life. So maybe you'd want to move them to the extended release oxycodone. Well, why would you want to do that? On the immediate release, you have the up and down. You have the peak trough every 4 or 5 hours, and the patients are kind of going into mild withdrawal every 3 or 4 hours. At a certain point, patients can't even tell if it's withdrawal or pain, and the only thing their brain understands is to take another oxycodone. So on an early opioid, you're getting rid of the peaks and the troughs and hopefully getting a steady state level in the brain and in the blood. Longer duration of action, maybe they'll be able to sleep better and not have to get up to take any medication. Yeah, okay. Other potential reasons, maybe they say, I want to try something new. Cost or insurance doesn't make sense because the IRs are usually cheaper than the ERs. But maybe adherence, maybe they won't take as many. Maybe you'll get better adherence with the long-acting. Okay, drug-drug interactions maybe occasionally be a reason. So when you go from a immediate release opioid to an extended release opioid, on the extended release opioid, you want to only initially use those that are recommended for opioid tolerant patients, and you'll see that slide coming up soon. However, in patients who are not opioid tolerant, you shouldn't use any transdermal fentanyl because of the high potency of fentanyls, or the long-acting hydromorphone. Hydromorphone is the most potent of the oral opioids. It is about 4 or 5 times as potent as morphine. Certain strengths of early opioids should not be used in people who are not opioid tolerant. Now, when you put somebody on an oral opioid or switch them from the IR opioid, there's a danger period of a new opioid, so that you have to monitor them carefully for the first few days. And then once they're on that extended release opioid, you're going to have to gently titrate the dose and increase it to get the appropriate amount of analgesia. They say supplement with an IR opioid, and we'll come to that in a minute. This is the breakthrough pain issue. Okay, but before we come to that, we have a concept called opioid-induced hyperalgesia. So if you think about it from a sort of an animal evolutionary point of view, it's very important for each of us to feel acute pain. And when you're on opioids, your pain sensitivity level should go up. You should become less sensitive to pain because you're on an opioid. But your body doesn't think that's a good thing, because now if you do step on a nail, maybe you won't realize it because of the opioid. So when you're on chronic opioids, your body is putting into effect counter-regulatory mechanisms to increase your sensitivity to pain. And so one of the phenomena that occurs in people on high-dose chronic opioids is that they become, paradoxically, more sensitive to pain so that they can feel acute pain. Now, how do you know this is happening? Usually the debate is the patient asking for more opioids because they have developed tolerance and they need more opioids, or are they asking for it because they have opioid-induced hyperalgesia? So if they have opioid-induced hyperalgesia, if you give them more opioids, the pain should increase, should not get better, whereas with tolerance, it should at least temporarily get better. With opioid-induced hyperalgesia, they should develop pain in new locations, should become more diffuse, they're more sensitive to pain, and the pain is just not improving. So usually high doses, and again, counterintuitively, if these people will agree to go down on their dose of opioids, they will have less pain. This happens. It doesn't happen that often, but it's definitely something to think about if you're going to have somebody on long-acting opioids for a long time. Going back to what is opioid tolerant, so these are just arbitrary doses that the FDA says make somebody opioid tolerant if they've been on these medications at these doses for a week or longer. And the only thing that's important here is that then they say that if they are opioid tolerant, then you can use the transdermal fentanyl patch or long-acting hydromorphone, but if they're not, then you shouldn't. Okay. I did tolerance and physical dependence, so I won't do that again. Now we come to a topic which I don't think is going to be too common and relevant, but it was in the heyday of the prescription opioid epidemic. And that is that somebody's on an opioid, usually a long-acting opioid. However, their pain is not getting better. They're taking increasing doses. They're having adverse effects. And so you would say to yourself, well, maybe if I changed from oxycodone to hydromorphone, or from hydromorphone to oxymorphone, maybe the patient will get better pain relief at a lower dose with less adverse effects. So that was the whole idea behind switching from one opioid to another, to get a better outcome with less adverse effects. And the idea here is that we all have slightly different mu-opioid receptors, and so the drugs are going to react differently in each individual. Okay. So in order to do this, you have to have an equianalgesic dose table, because you have to have some way of estimating what the dose of the new opioid you want to use is going to be based on the dose of the current opioid. And so there are many equianalgesic dose tables published. Some of them will have the drugs you're interested in, some will not. However, they're relatively limited because this is kind of only acute dosing. It doesn't take into consideration gender, age, ethnicity, culture, other things that might be important in making the switch, but this is what you have to use. This is an example of an equianalgesic dose table. They are usually all using the reference of a PO morphine. We're doing only the PO column. it's usually all keyed into 30 milligrams of morphine. So in this table, they're saying that 20 milligrams of oxycodone is equal to 30 milligrams of morphine. Sometimes this will be listed as 15 in a different table. Hydrocodone, they're saying, is 1-to-1. Other tables may have this as 20. All tables will have hydromorphone as the most potent oral opioid. So if you were going to switch somebody from morphine to oxycodone, you'd have to do this 3-to-2 conversion to figure out what the approximate equianalgesic dose of oxycodone will be. However, let's see if the next slide has the however on it. Well, this goes back to the rationale. Different mu-opioid receptors in different people. So here's drug 1 having a good impact on this subcategory of mu receptor in this person, but drug 2 does not have good activity at that receptor, better activity at other receptors. So again, if you were using drug 1 on a patient here, they wouldn't have, or vice versa, you'd have to find the right drug for the right person, and the way you would do that is through opioid rotation. The problem is that I'm on oxycodone and I'm tolerant to whatever dose I'm on. You're not going to switch me, let's say, to hydromorphone, and we don't know what the tolerance level will be because it's a new opioid, and that is called incomplete cross-tolerance. You can't assume that I'll be tolerant exactly the same way. So we have to account for incomplete cross-tolerance. And how do we account for that? We account for that by reducing the dose that you have figured out from the equianalgesic dose table by either 25 or 50%. You're going to reduce it 50% in older people, more frail people, people with polypharmacy, and maybe closer to 25% in people that are a little bit healthier. Although you say, well, why would a healthy person be on chronic opioids to begin with? But putting that aside, that's the general guideline. We'll do methadone on the next slide, so don't even think about methadone right now. But this is how you account for incomplete cross-tolerance by reducing the dose. Methadone is a tricky drug. None of the equianalgesic dose tables should be used when you rotate to methadone. Methadone has a very variable half-life. This is now discussing methadone for chronic pain, not for opioid use disorder. And in no instance should you ever give somebody on day 1 more than, let's say, 30 milligrams of methadone. I'd say even less, because the half-life can be up to 100 hours. Methadone is a very effective and good drug. You have to know how to use it. It can cause QT prolongation, and in general, opiate-naive patients should not be given methadone as their initial drug unless you really have expertise in the use of methadone. If you're switching to either transdermal fentanyl or buprenorphine, you have to use the dose conversion tables in the product insert. They're accurate and they work well. Oh, I wanted to hide that slide, so I'm just going to skip by it. Okay. There's a whole new category of opioid medications that are called abuse deterrent or tamper resistant. And so the idea here is that prior, you could take an OxyContin tablet, crush it up, and make it immediate release. You can't do that anymore. It won't crush. It's very hard to tamper with it. We don't want people to tamper with the capsules that they get. So these medications that are coming out and would have different mechanisms to make them abuse deterrent or tamper resistant. However, it's a little bit misleading. The most common way that people overdosed and died with prescription opioids was just by taking too many PO and swallowing them. And you can do exactly the same thing with the abuse deterrent. So don't be misled into thinking that abuse deterrent will completely negate overdose, opioid use disorder, misuse. It'll only prevent tampering of the product. These products are also much more expensive. They're all branded, and that's something you have to take into consideration as well. Urine drug testing. So urine is the most common bodily fluid that's used to test for drugs. Saliva can be used, and hair, HAAR, can be used as well. But you're going to use urine. We want to say that urine testing is done for the patient, not to the patient. In other words, we're not going to be cops. We want to monitor a person. we don't have much objective information, and a urine test is something that is objective. We want to identify if things are not doing well, if patients are using other drugs. So we have to tell the patient that we're not doing it because we don't trust you. We're doing it because it's a standard of care. Okay, so we want to get a baseline urine drug test. We want to be aware of how to interpret it, and we'll talk about this stuff in the next slide. So there are two ways you can do urine drug testing. The most common initial test is called a screening immunoassay. You can either do this in the in your office, called point of care. This is like the pregnancy test. It has the strips. You dip it into the urine. You either get 2 lines or 1 line, 2 lines negative, 1 line positive, and within 2 or 3 minutes you know what's in the urine. The only problem is you have to have the right strips. So if you want to test for oxycodone, that will not test positive if the strip says opiates. That will only be morphine and codeine. You will never get a positive for methadone, fentanyl, or buprenorphine unless the strip is specifically designed for those synthetic opioids. So that's important. The strip has to have the right drugs that you're looking for. There are false positives and negatives on this, but it works pretty well most of the time. You get the results quickly. You can send it to a lab and get it the next day. The backup is called confirmatory testing, gas chromatography, mass spectroscopy. This would work where your dipstick has positive benzo, but you don't know what benzo it is. Is it the alprazolam that you're prescribing? Is it clonazepam? Is it diazepam? And the GCMS will tell you exactly which benzo it is. And that's what this is used for. It's also used when people deny the results and say it can't be possible, so this might convince them that it is possible. Much more expensive, takes a longer period of time to come back generally. How long do drugs stay in the urine? Roughly for most drugs, about 3 days. Heavier use of marijuana, up to 30 days, but roughly 3 days. Cocaine gets in and out pretty quickly. You have to know a little bit about opioid metabolism. So for example, if you eat poppy seeds come from the opium poppy. It is definitely possible to test positive for morphine and or codeine from poppy seed ingestion. Heroin basically gets converted to morphine within a couple of hours in the body. So generally when people use heroin, you're going to get a positive morphine, and these other molecules can convert to each other, which is usually not going to be a problem. This happens in minuscule amounts. What about stopping opioids? Well, if the pain gets better and decreases, if they have a lot of adverse effects, or if they're not making any progress, you might say, let's stop. Or if they're having repeated difficult behaviors that you just cannot continue to prescribe under these conditions. Either you have to find somebody else who's willing to take over the case, or you're going to have to taper the person. So there's a whole, okay, this is what, these are new risk tools for determining is the patient developing an opioid use disorder while they're on the opioid. So I'm going to let that go because I'm going to run out of time. I don't want to do that slide. I want to get to this slide, which is tapering. It turns out that people on long-acting opioids for a long time who no longer have pain, who don't like the opioids, who have a lot of adverse effects, some of those people have a very difficult time tapering off. Every time they go down in a dose, they develop withdrawal, and they go back up. And there are some people who are not going to be able to taper off. That's why it's very important to decide before you begin the opioids whether this is reasonable, because there might be a physical dependence problem that you really can't resolve. And some people have suggested a new category called prescription opioid physical dependence. Not opioid use disorder, but can't get off the opioids even though I don't want to be on them. In any case, these parameters or paradigms of do this percent a week or this percent, they don't work in my opinion. You just have to do it very slowly, very gradually, taper people off, keep trying to do it over and over again till it works, switch to buprenorphine, consult an addiction medicine physician, but it can be difficult to taper people off, and they need to know that before they begin. But these percentages are too arbitrary for me. So a pain specialist, they're very hard to find these days. I would say they should have said a pain specialist and an addiction medicine specialist. I think addiction medicine specialists are very versed in opioid tapering. Oh, medicinal marijuana, a little thing on that. So here's Iowa, and you're one of the states that has medicinal use, but it has to be high CBD, low THC, which I guess means mostly from the hemp plant. And you see the other states have medicinal marijuana, and I think it's 10 states now have recreational marijuana. I want to do marijuana very, very quickly because I don't want to miss some other things that I think are more important. The bottom line, if you're an evidence-based practitioner or provider, the bottom line is there's very little evidence for effectiveness or efficacy of any of the cannabinoids for anything right now, maybe with the exception of neuropathic pain and definitely rare forms of epilepsy with cannabidiol called Epidiolex. The problem is that there are many cannabinoids that the use of cannabis has gotten way ahead of the science supporting it, although many people believe that it's good, many people are using it. They're using it in different forms. It's hard to know what people are using, what percent of THC is in the preparation, what percent of CBD. But there's very little evidence if you go through it carefully. There was a recent review on this, if you're interested, in JAMA. The guy's name, the author is Kevin Hill. And in a 2-page editorial, he went through all of this. Was published online August 9th, 2019. And again, I'm not that statistically sound, but the more you look in terms of PTSD, depression, anxiety, the evidence is just not there. As you know, there are some pharmaceutical cannabinoid medications like dronabinol, which has the indication for anorexia, wasting AIDS patients, nausea and vomiting and chemotherapy, and now the cannabidiol that I mentioned. But again, I don't want to go through these slides now. You can look at them later. They come down to the same conclusion, that the studies are not very good, that the products used are not one product, and it's hard to know how to analyze the data. And I just don't think we're there yet, even though it's widely used, reports from many people that it helps. And so I don't have a problem with people using it. I just don't think it's evidence-based yet. So that was a very, very brief cannabis, and I'm sure that some of you have different opinions on that. It's a very rapidly evolving area with a lot of controversy. So here's something very easy to say in a lecture: document everything you do. So educate everybody. I'm going to go through this one really, really quickly because we've done all of it. Always read the product insert. These opioids come with a patient counseling document that gives them a lot of information. Some providers ask them to bring this in, and we go over it and discuss it, and there are little blank areas that you can write your instructions in. So I won't do this again. This is the side effects again. We've done it. Some of them you can get ahead of and treat, like constipation. Some of them are going to happen. You definitely don't want falls and fractures to happen. It's going to happen more often in people on benzos with the opioids. We did the don't tamper with any of this. Don't make them immediate release if they're not. Try not to drink alcohol, but if you do, separate it from the extended release tablet you're going to take. We did respiratory depression. Again, greatest risk, they say, when combined with a benzo. The signs of the thing, that this can be a little bit misleading. There are any number of patients who go on an opioid like Methadone for pain, take more than they should, lie down on the couch, they sleep, they're snoring heavily, which is a really bad sign. The family's really happy, look how peaceful, look how great they're doing. 2 hours later, they're dead. So heavy snoring is really a warning sign. Again, that might be the exacerbation of obstructive sleep apnea. But people need to know this, family need to know that these are the signs of people overdosing. And what should everybody have? Naloxone. So you all know what naloxone is. You have to educate the patient, but particularly the friends and family. It's important to first call 911 and then give naloxone. Most states now have relatively easy access to naloxone. This has become, I think, the favorite formulation, the Narcan nasal spray, because it has 4 milligrams of naloxone, which is more than these formulations. And with fentanyl now being so common, you need higher doses of naloxone and multiple doses to reverse a fentanyl overdose. I think in most states there's something called a standing prescription, and people can walk in and ask for naloxone, and I think the insurance usually covers it, or there's a copay, but it's available. And people say that if you prescribe an opioid, you should co-prescribe naloxone. Okay, this has become a big topic, storing these opioids. Forget the medicine cabinet. You can't put anything into an unlocked medicine cabinet anymore. You've got to have some kind of safe box with a lock on it, or some hidden compartment someplace. You particularly want to be careful if you have teenagers in the home. They're looking for these medications. Watch where they go with their friends. Tell the grandparents that they have to be careful about their medications. The storage became a big deal during the opioid epidemic. And the other thing that became a big deal is getting rid of the opioids. You know, you'd go to a dentist, you'd have a tooth pulled, you'd walk out with 60 oxycodones, you'd take 1 or 2 or none, and you'd put that bottle in the medicine cabinet, and somebody would eventually get their hands on it. How do you get rid of this? Sometimes the DEA has take-back days. You just drop it off. You can mix the opioids or the benzos or anything in coffee grounds or cat litter, seal it up, dump it in the trash, deface the label, throw the bottle away separately, or if you want to, just flush it down the toilet. May not sound environmentally okay, but it is okay. It's the only way you're supposed to get rid of a fentanyl patch, by folding it up and flushing it down the toilet. You're just not supposed to throw these things out without defacing them and somehow making them unusable. They say people go through trash cans and dumpsters. I don't know if that's true or not, but getting rid of this stuff when you no longer need it has become a big deal. Okay, last chapter, Opioid Use Disorder. This is my favorite chapter because I was the one that put it together. So this has to do with that interface of chronic opioids, chronic non-cancer pain, opioid use disorder. Oh, okay. So what is the risk for my patient? During the prescription opioid epidemic, everybody wanted to know, if I put 100 people on chronic opioids for back pain, what percent are going to get addicted? And the numbers that came out in the articles that were published in the 2000s were incredibly low. It would be something like 3% run the risk of addiction, which seemed very low because the background risk of addiction in the population is 10 to 15%. And the reason, I'll show you why it was that way, but the current thinking is about 30% of people who are placed on chronic opioid therapy for chronic non-cancer pain will develop a problem up to and including an opioid use disorder. The risk is always highest in anybody with a history of substance use disorder or any psychiatric comorbidity. So a definition of addiction. There's a complicated, comprehensive one from ASAM, American Society of Addiction Medicine, and this is reflecting, like with pain, that addiction is a multidimensional problem in reward and spirituality, motivation, and other circuitry in the brain. But if you want a simple definition of addiction, addiction is continued use of drugs or activities despite knowledge of continued harm to oneself or others. So continued use despite harm. I would argue if there's no harm, whatever you're talking about, like chocolate or The Sopranos, there's not going to be any addiction. Continued use despite harm. That's what addiction is. So these are the DSM criteria for substance use disorders, opiates, alcohol, anything. So importantly, tolerance and withdrawal don't count if the medication's prescribed. So that was one reason why the prescription opioid epidemic was flying under the radar. Then there are criteria for loss of control, which is a hallmark of all addictions. You cannot control what you're addicted to. You can't have one drink, you got to have the whole bottle. Negative consequences are your life's going down the drain, and yet you cannot stop using whatever you're addicted to. Let's say gambling, and all of this is going bad. And these days it's divided between mild, moderate, and severe. So what was happening during the opioid epidemic is that you were going to the provider, you were getting your prescription for 120 oxycodones, You weren't spending a lot of money. You weren't running around, and you'd go every month. And so this epidemic was brewing, but it wasn't visible because the DSM criteria were not adequate to pick it up. And so all of a sudden it kind of exploded when the overdose deaths started to go up dramatically. So a couple of more terminology issues. Physical dependence or tolerance doesn't necessarily equal addiction. People who are doing well, let's say, on methadone maintenance, no other drug use, using their time productively, they're physically dependent on methadone, but they're not addicted. They're not addicted because there's no harm. Somebody's on a benzo for panic disorder, they're taking the benzos as prescribed, they're physically dependent, but they're not addicted. This is a very important differentiation. Also, aberrant problematic behavior doesn't equal addiction. There might be some good reasons for this that you need to explore. So use the word addiction very, very accurately. Oh, back to the brain, sagittal section of the brain. We have those areas again, the analgesic area, the limbic system with the euphoric area, and the withdrawal dependence area. Again, if you're vulnerable, you take an oxycodone because you had a root canal. The vulnerable people are going to feel something in their limbic system. They're going to say, this opiate is magic. This took away all my pain, all my suffering. I forgot about the incest. The world looked beautiful to me, and that is going to drive continued use. That's the risk you take with giving people opioids. Those who are vulnerable, in addition to hopefully getting some analgesia, are going to get something in this part of the brain, the limbic part of the brain, which is what the part of the brain involved in addiction. When we say addiction is a brain disease, we mean that it changes the neurotransmitter levels in this part of the brain. It strengthens the limbic system and it weakens the prefrontal cortex. So you're not as good at controlling what you shouldn't be doing. You've lost the ability to control. This is the problem with adolescents. Their prefrontal cortex is not yet well developed. Their limbic system is developed, and they go do risky things because they can't say no from the prefrontal cortex. So, addiction doesn't occur overnight. When people show up for addiction treatments, usually going on for years. And there are stages of addiction. It starts with intoxication, euphoria, binging. Feels good. People are high. They like the alcohol, they like the cocaine, or they like the opioids, the prescription, heroin. And this is subserved by certain neurotransmitters, dopamine and the opioid peptides, the endogenous opioids like endorphin. As drug use continues, they no longer feel good. They no longer feel high. Now they become physically dependent. They're going into withdrawal every 3 or 4 hours. Most drugs that people get addicted to are short-acting drugs. And so they continue to use even though it's not doing anything pleasurable. This has been termed the dark side of addiction or negative reinforcement. The reason they continue to use is because they want to treat their withdrawal. So now they're in a vicious cycle. They're not feeling good from the alcohol and the oxycodone, but they continue to use. And this continues to go on, and they're preoccupied, they're craving, and unless somebody treats them, the cycle just stays here, and they need treatment. And treatment does work for addiction. We have very good treatment. So I didn't do this. That this part of the negative affect is subserved by corticotropin releasing factor and by dynorphin, and the craving, glutamate, the people, places, and things, the relapses, is subserved by glutamate. So when we say that the drugs hijack the brain, this is what we mean. That the drugs now provide more pleasure than the natural rewards of food, sex, water. That's a brief overview of addiction. So who's most vulnerable to getting addicted to these drugs? This is an amazing statistic. 19% of people who have mental health disorders in the United States receive 51% of the prescribed opioids. These are the people most likely to have trouble with the opioids. This has been termed adverse selection. Every day that you stay on a chronic opioid increases your risk of being on it longer and longer and developing an opioid use disorder. And that's why in many states, for acute pain, there's a limit on how many days of opioids you can prescribe. In New York, it's only 7 days. Leaving the EDs in New York, you can only leave with 3 days. And it's very important to prescribe the least dose for the least number of days if you want to keep the vulnerable people out of trouble. How do we treat opioid use disorder? Well, actually, it's the addiction that is the most amenable to treatment because we have the best medications. So the gold standard has always been methadone, which is Schedule 2. We have buprenorphine now, which is a very effective drug, Schedule 3. Different regulations here. This can be done in an office-based setting, only in a methadone clinic. Naltrexone, not controlled, an opiate antagonist. These are agonists. Anyone can do this, both pills and more commonly injectable now, once a month. We think adding psychosocial treatment enhances outcome. And let's see, I'll leave that other part out. That's not important for today. Now, this comes up all the time. What about somebody with pain and an opioid use disorder? Well, it's a tricky issue, but you have to treat both because otherwise the pain will be a trigger to relapse. People are not going to stay in pain. People with opioid use disorder have increased pain sensitivity, so don't use other potentially problematic medications like benzos. If you can, get that multidisciplinary program. And buprenorphine. Buprenorphine has been shown to be effective to treat both opioid use disorder and opioid and pain at the same time. Get significant others involved and keep checking the PDMP. So we want to be careful about opioid analgesics with benzos, with nicotine, with alcohol. All of these things give you a much more negative outcome for a variety of different reasons. People who are tobacco addicted, nicotine dependent, have less of an analgesic response to opioids than people who are not. And buprenorphine, people are a little bit mixed up about this. If you're using it for pain, you don't need a waiver. If you're using it to treat opioid use disorder, then you do need a waiver. A waiver is not that hard to obtain. I'll leave you get the information online. It's currently the most popular medication prescribed for opioid use disorder, much more than methadone and naltrexone. Has a plateau effect, which makes it safe in terms of respiratory depression. Again, it's really a very safe and effective molecule. If you're treating pain, use the formulations that are approved for pain, not for opioid use disorder. So one is a 7-day transdermal patch, and the other is a BID buccal mucosal film. No waiver is required. There are no patient limits. The rest of it now is resources, and there are so many resources dealing with this topic. You'll be able to look at that yourself. We stop here. I am going to ask Adam, if you're on the call, to make a few, to just tell them how you get your CME and the evaluations, and you got to take a post-test to make it all work. Are you on, Adam?
Yeah, hi, Dr. Salsas. Can you hear me?
Yeah, I can hear you.
Great. Hello, everyone. Thanks for attending. Dr. Salsas, I think it might be in the next slide. There is a link to fill out a brief evaluation. Once that's filled out, we'll be able to send you certificates for CME. So you'll just want to go to that link, and if you don't get it down now, I can also email it to you shortly. But you'll want to just fill out, it's a pretty brief survey, and then we'll be sending you your certificate for CME. Thanks, everyone.
Let's see. So I know it's late and ran over a little bit. I guess if there were one or two questions, we could do that. I'm looking at the list here. I'm not seeing anything. Well, maybe I didn't go down far enough. Kate, are you still here?
Yeah, yep, I'm here, and I've got a couple questions that I kept an eye on. So one of them is, I'm an MAT provider starting pain management groups for substance users. Any thoughts about chronic as in multiple times a day for years, marijuana users, and the impact on pain, dosing, and efficacy?
Wow, that was a long question. I'm not sure I got the whole thing. Can you summarize it, Kate, somehow?
Yes. Okay. So so basically, what are your thoughts about those who are using marijuana multiple times a day for years, and that impact on pain, dosing, and efficacy?
Okay, I'm gonna answer what I think might be underlying the question. A couple of years ago, a few articles came out which suggested that in those states that had medical marijuana, opioid overdose deaths had gone down. And the interpretation was that people with chronic pain who had access to medical marijuana were using less opioids and using marijuana instead, and that was a real net benefit. But on closer examination of those data and statistics, it didn't really turn out to be true. There were a bunch of confounding factors involved. I would be concerned about anybody using marijuana multiple times a day. I mean, there is something called a cannabis use disorder. I would be particularly concerned in any teenager or young adult who is doing that. But currently, the feeling is that marijuana does not result in less opioid use. And there have been a couple of articles recently showing that people who do use marijuana use more prescription opioids and misuse them more than people who don't. So I don't know about the rest of you, but I'm very confused about some of this controversial data. So that's all I know right now, and I'm not sure that I answered the question.
Okay, so there's another question that I'm gonna see if we come back to that one, but another question that says, do you support continuous electronic physiologic monitoring of patients taking opioids? And the same person just also added, should have mentioned the continuous monitoring would enable opioid-induced respiratory depression to be detected in time to prevent overdose death or brain damage.
Well, I see that that's Kay. Kay, I'm not familiar with continuous electronic physiologic monitoring of patients taking opioids. I suppose maybe in some patients deemed high risk, it would be a good thing to do, but I don't know about doing it for the majority of people, so I'd have to learn about that and see what that entailed and how cumbersome it was and what the cost was, etc., and if there were false readings that would cause panic. I don't know. I think if opioids are prescribed carefully and judiciously, that in the majority of patients it might not be needed, but I don't know enough. I don't know anything about that. So I have to pass on that.
Okay, do you have time for one more question?
Yeah.
Okay, so we have one more. In which of the pain categories would you put chronic migraines, as in 8 to 20 days per month?
Boy, that's a good question. That is a good question. I'm going to have to say, I'm going to have to punt on this one and say, I think maybe that chronic headaches need to be a category all their own. So yeah, it's not nociceptive. I don't think it's neuropathic. I guess, no, well, maybe it's nociplastic, where the origin of the headache is not known. Yeah, that's a really good question. I'm going to have to ask other people about that. I don't know. I don't have an answer on that.
Yeah, and feel free if people have questions about that and they want to follow up with us, and we can look into that here at our center. And yeah, we just really appreciate the questions. And yeah, at this time, I just want to thank Dr. Salsitz so much for this really in-depth conversation and training. And just want to thank everyone for being a part of this. And I just want people to know we did record this, so we'll be sending anyone who registered a link to the recording. There are handouts which we will include in our follow-up emails, and we do have a short survey as well that you should be automatically redirected to. So we'd appreciate. I know it's a lot to do 2 surveys, but we'd love to hear from both ends of the spectrum, just what your thoughts were about this. And And then, as well as just reminding everyone, there's the CEUs that we offer through NEDAC, and then the CME options through ASAM that you can do with that additional piece. And so feel free to email me if you have any questions about that. I'm the one who sent out the reminder email today, so feel free to reply to me if you have any questions about any of those things. And then, so Dr. Salzitz, do you have anything else you wanted to say before we finish up here?
No, I thank everybody on the webinar, and those were great questions, and I'll have to go do some more studying. Thank you.
Wonderful. And yeah, I just want to thank Dr. Salzitz and Adam at ASAM, and just want to show our appreciation for letting us share this with our webinar participants. So we appreciate it. And yeah, again, thanks everyone for joining, and we hope you all have a great day.
Bye-bye.